Good evening. At the outset, I will like to thank the organizers for giving me this opportunity. Really, it's a great pleasure to be there with you. The topic which has been given is very important one in day-to-day practice for diabetologists. It's a diabetic neuropathy, that is a microvascular complication related to the diabetes. Dear friends, we know that 1% reduction in HbA1c will reduce microvascular complication in diabetes by almost 30 to 35%. This was the study which has been published in London, that is the UKPDS trial, which was lasted for almost 20 years, and it has shown clear cut that aggressive control of diabetes is also very important. At the same time, if you reduce the HbA1c by 1%, it will reduce microvascular complications by almost 35%. So we know that diabetes can cause micro and macrovascular complications. We know that what microvascular complications are important is diabetic retinopathy and mainly diabetic peripheral neuropathy and diabetic nephropathy as well. And macrovascular complications are mainly cardiovascular complications, which we say in day-to-day practice. But the most important effect by reducing HbA1c is on microvascular complications, including diabetic retinopathy and diabetic neuropathy. So it is very important to control the diabetes in these patients. And there are so many reasons why you get neuropathy. One of the most important cause for neuropathy is it can be a drug induced, or it can be most of the times it's alcoholic. So you have to rule out other causes before labeling this as a diabetic neuropathy. Even I can say that if the patient has got impaired glucose tolerance, this is the earliest sign which you can detect in these type of patients. And so many times in our clinical practice, what happens is that if we do the peripheral nerve testing and we find neuropathy, so first thing what we do is do blood sugar levels of these patients, which will be helpful to label these patients as diabetics. And surprisingly, we can say that we could detect these patients as diabetics. That means early detection of the diabetes and early treatment and early reduction in HbA1c is very important in this type of patients. So what is a diabetic neuropathy? Dear friends, diabetic neuropathy can be defined as the presence of symptoms and or signs of nerve dysfunction in people with diabetes after other causes have been excluded. Which other causes are mostly, as I already said, is most of the times it's alcohol, or it can be due to the drugs. So after exclusion of these causes, and if the patient has got neuropathy, you can label this patient as having diabetic neuropathy. We know the burden of the diabetes around the world is a huge burden on healthcare system, and India and China, we say that these are the capital of diabetes in the world. So we got a maximum number of diabetic patients, and we have to be very, very careful in treating these patients and preventing its complications, micro as well as macrovascular complications. This is the problem statement of the diabetic neuropathy, where we know that almost 45% of the prevalence of diabetic neuropathy in diabetic patient is almost 45%. And even it can be said that almost two-thirds of the patients of diabetes has got peripheral neuropathy. So all forms of diabetes of sufficient duration are vulnerable, including type 1 diabetes as well as type 2 diabetes. It may coincide with the CIDP, that is a continuous demyelinating polyneuropathy. It can be vitamin B12 deficiency, or it can be alcoholic neuropathy, endocrine neuropathies. So you may get diabetic neuropathy along with these things also. So you do not have a single exclusion of only whether patient has got diabetes. That doesn't mean that diabetic patient can be alcoholic also. Diabetic patient can have vitamin B deficiency also. Diabetic patient can have endocrine other problems also. And the additional causes in 10% to 15% of patients with diabetes are seen. So that means there are associated causes. Along with diabetes, we have diabetic peripheral neuropathy. It cannot be only a diabetes, but you have to find out other causes as well. It is a prevalence of almost 5 to 100%. It can occur with impaired glucose tolerance and metabolic syndrome without hyperglycemia. Most common form of neuropathy it is the most common form of neuropathy in the developed countries. Even in UK, it has been said that 50% of the patients of diabetes has got diabetes with neuropathy, peripheral neuropathy. More hospitalization than all diabetic complications, and 50 to 75% of non-traumatic amputations are because of diabetic foot. So it is very important to prevent this complication, because diabetic neuropathy can cause ulcers. Ulcers may get caused again after some days, if they are not treated properly, may cause gangrene. And gangrene Once the gangrene is developed, you have to amputate the foot. So 50 to 75% of the non-traumatic means the patients who don't have accidents. There are maximum number of diabetic patients who are amputated in the world. Most important signs, weakness and ataxia are also seen. That is likelihood of falling, and particularly in older patient, if they fall down because of ataxia and weakness, they are likely to get the fractures, particularly femur neck fracture. 25% had symptoms. That means all diabetic patient who has got a peripheral neuropathy, that doesn't mean that they will get a symptom. And 50% had neuropathy after ample stress or vibration test. 90% positive on sophisticated test of autonomic nervous dysfunction for peripheral sensation. Major morbidities: foot ulceration, gangrene, and limb loss. Amputation risk is almost 1.7 times, and 12-fold if deformity is there, and 36-fold if history of ulceration. What are the risk factors for the development of diabetic neuropathy? Most important thing, which already I have said, is elevated HbA1c levels. That is poor glycemic control. Long-standing diabetes without good control are likely to get the diabetic peripheral neuropathy. Then another important is hypertension, cigarette smoking, alcohol, and hypertriglyceridemia. What are the risk factors for the development of diabetic neuropathy? There are some non-modifiable risk factors like obesity. You cannot modify age. Then it is more common in male sex, height, family history of neuropathic disease, longer duration of diabetes, ApoE type of genotype, adipose reductase gene hyperactivity, and AC angiotensin converting enzyme genotype. How you stage, how you classify these patients of diabetic neuropathy? Patients don't. N0 is no symptom or signs of neuropathy. N1, the patient who are asymptomatic, but only signs of neuropathy are present, that is mild signs. N2 is symptomatic neuropathy, where patient gets complaints of severe pain in the both lower limbs. And third is N3, it is a disabling polyneuropathy. What are the types of polyneuropathy? Most important is distal symmetrical polyneuropathy. It is one A is acute sensory neuropathy. So what are the symptoms we get? Is burning discomfort in feet, patient get hyperesthesia, deep aching pain, sharp stabbing or electric shock like sensations in lower limbs. Patient gets weight loss, depression, erectile dysfunction, and nocturnal exacerbation because of clots irritating and hyperesthetic skin. Then distal symmetrical polyneuropathy. It is acute sensory neuropathy, allodynia on sensory testing. What is allodynia? It means even a small touching also cause pain. That is allodynia. That is excessive sensations. Is allodynia. A normal motor examination and reduced ankle reflexes. That is acute sensory neuropathy, distal symmetrical polyneuropathy. Most of the time, these patients get symmetrical polyneuropathy in both lower limbs. That is, we call it as a glow and stalking type of anesthesia, followed by or paresthesia, which is in the distal parts of the limb, which can progress toward the other parts. Poor glycemic control may follow an episode of ketoacidosis. Then there is associated weight loss and eating disorders. It may develop after sudden improvement of glycemic control. That is insulin neuritis, it is called. It is because of sudden ischemic episodes patient gets and it causes insulin neuritis. Then blood glucose flux in genesis of neuropathic pain. There is a degeneration of myelinated and unmyelinated fibers. More common in diabetes mellitus with mitochondrial tRNA mutation at 3243 level. Neural ischemia by sudden improvement of glycemic control, which I already said, which cause still effect with arteriovenous shunting. In management, so we should have stable glucose control is the most important thing. Onset, acute or subacute, severe symptoms resolve in less than a year. Then there is this another class is a chronic sensory motor symmetrical neuropathy, which is the most common neuropathy seen in diabetic patient. Most common diabetic neuropathy. Three-fourths of all diabetic patients of neuropathy has chronic sensory motor neuropathy. Since there is a sensory predominant autonomic correlate with severity, there is minor involvement of distal muscles of lower extremities, sensory stalking, glow distribution, stalking and glowing distribution, length dependent pattern, and advanced sensation impaired over wedge-shaped area of chest and abdomen. Then there is large fiber neuropathy, which patient gets a painless paresthesia beginning at the toes and foot. There is impaired vibration sensations. There is a diminished reflexes. Patient gets ataxia because of motor involvement, secondary to sensory deaffirmation. Then there is often asymptomatic sensory deficit is seen on examination. Then there's small fiber neuropathy. Patient get deep burning, stinging, aching pain, allodynia, that is a excessive sensation of pain to light touch. Even if you touch the patient lightly, patient gets a pain, that is allodynia. Pain and temperature are impaired. Relative preservation of vibration sensation, and then deep tendon reflexes, often accompanied by autonomic neuropathy and may develop soon after the onset of type 1 diabetes. There is a distal joint destruction, so causing acrodystrophic neuropathy. Chronic foot ulceration in 4 to 10% of patients due to unnoticed tissue damage, vascular insufficiency, and patient getting secondary infection. The neuropathic arthropathy, that is a Charcot joint, we label it as, in patients with foot ulcers and autonomic impairment. Small joints of feet are also affected. There is a diabetic pseudotypes, which causes lancing pain, loss of joint reflexes. Diabetic pupillary abnormalities are also seen. Then most important class of neuropathy in this is a diabetic autonomic neuropathy. You get sensory motor, you get sensory motor and autonomic nervous dysfunction. It correlates with the severity of somatic neuropathy. Subclinical impairment of CVS, gastrointestinal tract, genitourinary dysfunction also you can get it. Then patient gets orthostatic hypotension, which is a very important sign in patients of diabetic autonomic neuropathy. There is a patient has got resting tachycardia. There is a diminished heart rate response to respiration. The vagal degeneration of heart, the high resting pulse and loss of sinus arrhythmia. Painless or silent myocardial infarction, which is very common in diabetic patients. Even so many times patient come to your clinic without any chest pain and ECG showed that this patient has got myocardial infarction. We label this patient as a painless myocardial infarction because of diabetic and autonomic nervous dysfunction. These are the features of diabetic autonomic neuropathy. There is symptomatic involvement, gustatory sweating, respiratory arrest, postural hypotension, gastroparesis, diabetic diarrhea, which is also very common, neuropathic bladder. You get either incontinence or frequency of urination. Patient get erectile failure, neuropathic edema, and Charcot's arthropathy. What are the subclinical abnormalities? There is abnormal pupillary reflexes. There is a esophageal dysfunction. Either you get GRD type symptoms, patient complains of vomiting so many times. Then abnormal cardiovascular reflexes. There is blunted counter-regulatory response to hypoglycemia. That means you don't get tachycardia, sweating, and all these things because of hypoglycemia. It is very classical in patients of diabetes with autonomic nervous dysfunction. There is increased peripheral blood flow. What are the investigations which we recommend in this type of patients? The most important is that you have to do a urine analysis for protein glucose microscopy for evidence of nephropathy, which is very, you have to find out urine for microalbumin. Then HbA1c group for finding out the last 3 months blood sugar levels. Then urea, electrolytes, creatinine, LFT, including GGT. Then thyroid function test you have to do, serum protein electrophoresis, vitamin B12 levels. Then assess the symptoms like muscle weakness, muscle cramps, pricking number of pain, vomiting, diarrhea, poor bladder control, and sexual dysfunction. These patients may require X-ray and ultrasound as well. Then you have to search for GI motility abnormalities of esophagus, stomach, gallbladder. So esophageal study is also required. Then stomach, gallbladder, bowel, fecal incontinence sometimes you get in this patient. There is a delayed gastric, there is a gastroparesis, which is very common in diabetic patients. And these patients complaints of nausea, early satiety, and bloating and belching is very common in these patients. Diabetic diarrhea due to small intestinal involvement at night particularly, and which is in paroxysms. Constipation due to the colonic hypomotility is more common than diarrhea. And there is a bacterial overgrowth may occur because of sluggish movements of the intestines. There is impaired bladder sensation, first symptoms of genitourinary dysfunction. Bladder atony also you get, so you have to find out the bladder tone. Prolonged intervals between widening urinary retention and overflow incontinence. Patient wide every few hours to prevent urinary retention. So patient used to go for urinals so many times in a day and night. Impotence is often first manifestation in men, occurring in more than 60% of the patient. Both erectile failure and retrograde ejaculation are also seen. Impotence usually is associated with distal symmetrical polyneuropathy. Then pseudomotor abnormalities like distal anhydrosis of facial and truncal sweating, heat intolerance, then gustatory sweating, profuse sweating in face following food. Pupillary abnormalities are also seen, that is a constricted pupil with sluggish reaction, almost in 20% of the patient. There is a blunter response to hypoglycemia, that is inadequate sympathetic. We don't get tachycardia in these patients because of inadequate sympathetic and adrenal response. Unawareness of hypoglycemia complicates intensive insulin treatment. The proximal diabetic neuropathy, that is a diabetic amyotrophy or lumbosacral radiculopathy, is seen in some patients. That is, diabetes may cause proximal neuropathy, that is diabetic amyotrophy, which is common in some patients because patient is not able to get up while after sitting also. There is a thoracic radiculopathy and proximal or diffuse lower extremity weakness. There is different representations of involvement of roots of proximal nerve segments. There is asymmetrical weakness and wasting of pelvic-femoral muscles may occur abruptly or stepwise in individuals with diabetes older than 50 years. Patient may develop long-standing non-insulin diabetes mellitus during poor metabolic control and weight loss, but can occur in mild and well-controlled diabetic or be presenting. It can be a presenting feature. Then sometimes patient may get truncal neuropathy, T4 to 12 radiculopathy, pain or dysthesia is very common in these type of patients. There is a bulging of abdominal wall due to weakness of abdominal muscles. There is an isolation or with lumbosacral radiculopathy. Can mimic intra-abdominal, intrathoracic or intraspinal disease or herpes zoster. May pre-exist for several months before resolution within 4 to 6 months. EDX, that is active degeneration in postprandial and postspinal and abdominal muscles. There is a focal anhydrosis in area of pain with thermoregulatory sweat test. Then you can get limb mononeuropathy, that is nerve infarction or entrapment of the nerve. Infarction, it is because of abrupt onset of pain, variable weakness and atrophy. Atrophy, median ulnar fibular nerve commonly are affected. There may be entrapment, more common than infarction. EDX shows agonal loss in nerve infarction, conduction block or slowing in entrapment. Diabetes mellitus in 8 to 12% of patients with CTS. Aggravation of ischemia in nerves with chronic endoneural hypoxia is seen. Sometimes you get monotherapy, you get mononeuropathies, multiple mononeuropathies, which is a scattered one. That is a mononeuritis complex, replaced as rarely due to inflammation. It is the involvement of two or more nerves. Onset is abrupt in one nerve. Other nerves are involved subsequently. Multiple mononeuropathies involving proximal nerves considered cause of amyotrophy. Infarction results occlusion of vasa nervorum. There is a systemic vasculitis be considered in a differential diagnosis of these patients. Then cranial mononeuropathy. It is also very common if the patient has got a facial nerve involvement. First thing which we rule out is the diabetes. Third nerve palsy is also common. Pupillary sparing with ischemic infarction of the centrifascicular oculomotor axons. There is a peripheral pupillary motor fiber spared due to the collateral circulation. Because of good collateral circulation, they are spared. Fourth, sixth, and seventh nerves are also affected. Bell's palsy, which is very common in diabetes, and a rhinocerebral mucormycosis and malignant external otitis is also sometimes seen. This is a comparison of features of mononeuropathies and entrapment. You see how the onset is. Mononeuropathy, you get a sudden onset. Entrapment, you get a gradual, because the entrapment is always gradual. And neuropathy, it is a gradual because it takes time to develop neuropathy. Pattern, single nerve in mononeuropathy, but maybe multiple also affected. Entrapment, single nerve exposed to trauma. Then in neuropathy, distal symmetric polyneuropathy is seen. What are the nerves which are involved in mononeuropathy? Cranial nerves, mainly third, sixth, and seventh, ulnar or median and peroneal. In entrapment syndrome, you get median nerves, ulnar, peroneal, medial and lateral plantar. Then in neuropathy, mixed motor and sensory autonomic nervous dysfunction can be seen. In natural history, mononeuropathy, so many times it resolves spontaneously. Entrapment, it is a progressive because of some pressure. Unless you reduce the pressure, or then and then only patient gets relieved. Then neuropathy, it is a progressive. What is the treatment? It is a symptomatic in mononeuropathy. In entrapment syndrome, most important is rest, splints, local steroids, diuretics, or surgery. In neuropathy, most important, as already I said, is the tight diabetes control. Sometimes if you have to use other drugs like pregabalin, duloxetine, antioxidants, then distribution of sensory loss. In mononeuropathy, it is areas supplied by the nerve. In entrapment, areas supplied beyond the site of entrapment. In neuropathy, distal and symmetric, glow and stalking type of distribution. What are the signs? Course of assessed clinical signs pioneered by Dick, who first described the NDS and later the neuropathy impairment score. A modified NDS used in several studies can be used in community also. That is, if the score is 0, if the sensations are good, the mild impairment of sensation, you get 1 score. If there is a moderate impairment, there is 2 score. So it is a score like this. Shown to be best predictor of foot is ulceration and best neuropathic endpoint in large prospective community study. The maximum NDS is 10 with a score of 6 or more being a predictor of foot ulceration. If the score is more than 6, there are chances of getting foot ulceration. The neuropain assess the pain using both a neurotrip at one end of the pain and a 10 gram monofilament at other end. Was shown to be a sensitive device for assessing nerve function when compared with the simplified NDS. Electrophysiology is very important, and NCV's nerve conduction velocity is only gradually diminished in diabetic peripheral neuropathy, with estimates of loss of 0.5 minutes per second per year. Sensitivity but non-specific index on onset, detecting the subclinical deficits. It traces the progression. Changes related to glycemic control can reflect pathology in large axons, that atrophy, demyelination, loss of density, and can improve with effective therapy. Diagnostic test for autonomic nervous dysfunction is very important. Resting heart rate, if it is more than 100 beats per minute, is abnormal. Beat to beat heart rate variation is also important. At rest and supine, heart rate by ECG while patient breathes is at 6 per minute. Difference of more than 15 beats per minute is normal, but if it is less than 10 beats per minute, it is abnormal. No lowest normal value for the expiration to inspiration ratio of the RR interval is 1.17 in 20 to 24 years of age. Heart rate response is to standing. RR interval measured at beats of 15 and 30 after standing. Normally, reflex bradycardia, and the 13-15 minute ratio is 1.03. Heart rate response to the Valsalva's maneuver, which is very important test, and it can be done anywhere. Exhales into manometer to 40 millimeters of mercury for 15 seconds. Healthy subjects develop tachy and peripheral vasoconstriction during strain and overshoot brady. Rise in BP with release. They rise in BP with release. The ratio of longest RR to shortest RR should be 1:2. Systolic blood pressure response to standing. Systolic blood pressure measured supine. Patient stands, BP after 2 minutes. Normal response, fall of 10 millimeters mercury. Borderline fall of 10 to 29, and abnormal if it is more than 30 minutes. Diastolic blood pressure response to isometric exercise, that is, ask the patient to squeeze or hand grip the dynamometer to a maximum, then squeezed at 30% maximum for 5 minutes. And response for diastolic blood pressure is rise of more than 16 millimeters mercury in the other arm. Then ECG, QTC intervals, the QTC should be for 440 milliseconds. Neurovascular flow using non-invasive laser Doppler measures for finding the flow. Then radionuclide cardiac imaging can be done. The most important part of this today's talk is management of diabetic neuropathy. Symptomatic management, then exclude non-diabetic causes, malignant diseases, metabolic disorders, toxic like alcohol, infective like infections like HIV infection, then any iatrogenic causes that has to be ruled out. That most common is isoniazid, which we use in treating the patient for diabetes, then vinca alkaloids, medications related to chemotherapy, that HIV treatment, Explanation, support, and practical measures, e.g., bed, cradle, a lift bed, clothes of hyperelastic skin, as assess level of blood glucose control profiles, aim to optimize stable blood glucose control, and consider pharmacological treatment. Control of hyperglycemia is the most important thing. Open label multi-control studies suggested that near normal glycemia is helpful in painful neuropathic symptoms. Stability of glycemic control equally important to level up to achieve control of peripheral neuropathy. Because if you have got a blood sugar levels, lot of fluctuation, that's not a good. So you should have a very stable blood glucose control to relieve from the symptoms. Lack of appropriately designed control study. Generally accepted that intensive diabetes therapy aimed at near normal OSA should be first step in the treatment of any form of diabetes peripheral neuropathy. Then the most important is pharmacotherapy. First, control the blood sugar. Then pharmacotherapy is required in so many patients in day-to-day practice. There is no evidence to support non-steroidal anti-inflammatory drugs. Then tricyclic drug. There are several randomized controlled trials. The mechanism is inhibition of norepinephrine and or 5-hydroxytryptine reuptake at synapses of central descending pain axonal system. Antagonism of NMDA mediating hyperglycemia and allodynia. Rapid onset suggests a mode of action, not primarily relief of depression. Use is restricted because of the frequency and severity of the side effects. Most expensive and most experienced there is maximum with amitriptyline and imipramine. It can be taken once a day in the evening. Disprimamine also useful drug, better tolerated than amitriptyline, but side effects are drowsiness and lethargy. Most common drug used is amitriptyline in day-to-day practice. The side effects are drowsiness and lethargy. Anticholinergic side effects, particularly dry mouth. In case of painful neuropathy, resistant to tricyclic drugs, combination with major tranquilizers, amitriptyline and transcutaneous electrotherapy sometimes used. SSRIs are used to inhibit presynaptic reuptake of 5-HT, not norepinephrine. Paroxetine, but not fluoxetine, associated with significant pain relief. Citalopram 40 mg per day was confirmed to be effective in relieving neuropathic pain, but less effective than imipramine. Side effects are less common with SSRI. Anticonvulsants used for many years, limited evidence, but phenytoin and carbamazepine in diabetic neuropathy. But most important anticonvulsants used nowadays in day-to-day practice is gabapentin. It is now widely used in a large controlled trial. Significant pain relief with reduced sleep disturbance was reported using dosage of 900 to 3600 milligram per day. In a recent review of all the trials of gabapentin for neuropathic pain, it was concluded that dosage of 1800 to 3600 milligram per day of this agent were also effective. Then lamotrigine, it is anti-epileptic agent with or at least two anti-nociceptive properties. In a randomized placebo-controlled study, Eisenberg et al. Confirmed the efficacy of this agent in patients with neuropathic pain. Then antiarrhythmics like mexiletine is a class of 1B and antiarrhythmic structural analog of lignocaine. Efficacy in neuropathic pain confirmed in controlled trials and reviewed. Dosage used was 450 milligram daily, is lower than that used for arrhythmia. Regular ECG monitoring is required and long-term use of mexiletine cannot be recommended. Then other agents like tramadol, that is opioid-like centrally acting drug, non-narcotic analgesic. Although first trial was 6 weeks duration, subsequent follow-up studies suggested symptomatic relief could be maintained for at least 6 months. Side effects are common, similar to other opioid-like drugs. Similarly, 2 randomized trials have confirmed the efficacy of controlled release oxycodone for neuropathic pain in diabetes. Opioids such as oxycodone may be considered an add-on therapy, but we are not using it. Topical and physical treatment. Topical nitrate, a recent study suggested that local application of isosorbate dinitrate spray was effective in relieving pain and burning discomfort. Then capsaicin, alkaloid in red pepper, depletes substance P and reduces chemically induced pain. Several control studies combined in mega-analysis seem to provide some evidence of efficacy in diabetic neuropathic pain. Only recommended for up to 8 weeks of treatment, useful in localized discomfort. Then acupuncture The role is also doubtful, but sometimes patients get tired and go at so many paces. Unmasked studies reports support its use. In a recent report, benefits lasted 6 months. Reduced use of other analgesics, so it can be used as add-on therapy. Conduct of potential blinded studies of acupuncture is problematic, although placebo response is possible with acupuncture. Then other physical therapies like percutaneous nerve stimulation, static magnetic field therapy, electrical spinal cord stimulation. A case series of patients with severe painful neuropathy and response to conventional therapy suggested efficacy of using an implanted spinal cord stimulator. This is evidence-based guideline for treatment of painful diabetic neuropathy. Anticonvulsants, if clinically appropriate, pregabalin should be offered for the treatment of peripheral diabetic neuropathy. It is a level A indication. Gabapentin and sodium valproate should be considered for the treatment of peripheral diabetic neuropathy. It is a level B indication. There is insufficient evidence to support for refute use of topiramide for the treatment of peripheral diabetes, that is level U indication, and the oxycarbamazine, lamotrigine, and lacosamide should probably not be considered in the treatment of diabetic peripheral neuropathy. Antidepressants like amitriptyline, venlafaxine, duloxetine should be considered for the treatment of peripheral diabetic neuropathy. It is a level B indication. Data is insufficient. Venlafaxine may be used added to gabapentin for better response. It is a level C indication, and there is insufficient evidence to support or refute the use of decipramine, imapropine, fluoxetine, or the other combination of nortriptyline and fluoxetine in the treatment of diabetic peripheral neuropathy. Then opioids, like the use of opioids for chronic non-malignant pain has gained credence over the last few days. That both tramadol and dextromethorphan were associated with substantial adverse events like sedation, nausea, and constipation. The use of opioids can be associated with the development of novel pain syndromes such as rebound headache. Chronic use of opioids leads to intolerance of frequent escalation of doses. Other pharmacological agents, like capsaicin and isosorbide dinitriles spray, should be considered for the treatment of peripheral diabetic neuropathy, level B indication. Clonidine, pentoxifylline, and mixetylene should probably not be considered. The lidoderm patch may be considered for the treatment of peripheral diabetic neuropathy, level C indication. There is insufficient evidence to support the refute the usefulness of vitamins and lipic acid in the treatment of peripheral diabetic neuropathy. Although capsaicin has been effective in reducing pain in peripheral diabetic clinical trials, many patients are intolerant for the side effects. This is a summarization of recommendations. Level A, level B. Level A is pregabalin 300 to 600 milligram per day. Level B is gabapentin 900 to 3600 milligram per day. It can be given in such doses. That is sodium valproate, venlafaxine, duloxetine, amitriptyline, dextromethorphan, morphine, tramadol, all these comes under the level B indications, and not recommended are oxycarbamazepine, lamotrigine, lacosamide, clonidine, petoximylin, mexilitine, magnetic field treatment, and low intensity therapy or key therapy. Autonomic nervous system, how you are going to treat autonomic neuropathy? Head of bed elevated 6 to 10 inches, then prevent salt and water losses during night and combat supine hypertension. 2 cups of strong coffee or tea with meals. Frequent small meals. Daily fluid intake should be more than 20 hours per day, and salt ingestion 10 to 20 grams per day. Elastic body stockings may be beneficial for reducing the venous competence of the bed, but poorly tolerated. Plasma volume expansion can be can be treated with fludrocortisone. Non-steroid anti-inflammatory drugs which inhibit prostaglandin synthesis, ibuprofen 400 mg QID, pentoxifenil, propranolol once used to manage orthostatic hypotension. Then most common used and recommended drug nowadays, midodrine, an alpha-adrenergic agonist, causes vasoconstriction, also is effective. Subcutaneous recombinant human erythropoietin, effective in some patients with orthostatic hypotension and anemia. Octreotide may improve orthostatic hypotension. Delayed gastric emptying related with metoclopramide. Diabetic diarrhea treated with short course of tetracycline or erythromycin. Clonidine reports to reduce troublesome diarrhea. The vasodilators treatment with AC inhibitors has been shown to improve electrophysiological measures of nerve function in mild neuropathy. The short-acting vasodilators like isosodiol dinitrate has been shown to improve the painful symptoms, but its effects on deficits and electrophagy are unknown. The take-home message for today's talk is diabetic neuropathy occurs in almost 45% of the patients with diabetes. Metabolic and vascular factors are implicated in pathogenesis. The most common type is distal symmetrical sensory-motor neuropathy. Exclude non-diabetic etiologies in these patients before labeling the patient to be a diabetic neuropathy. Most important thing in treatment is stabilize his diabetes glycemic control. Tricyclic drugs like amitriptyline 25 to 150 milligram before bed can be used if the patient has got painful neuropathy. Then anticonvulsants like gabapentin, a typical dose is 1.8 grams per day. Opioid or opioid-like drugs like tramadol or can be used sometimes if the patient has got severe pain. Drugs targeting pathogenic processes are in the development and may be available in near future. Thank you very much.